Okay, let's start with respiratory diagnostics. These are procedures that evaluate our patient's respiratory status. We check indicators like oxygenation, lung function, integrity of their airway. So we're going to look at a few of these. When pulse oximetry to begin with, we're all very familiar with that. You guys do a great job. It's non-invasive and it checks the oxygen saturation of the blood, but it is not a replacement for ABGs. And so you're going to use this as a quick indicator for conditions or situations where your patient's respiratory status needs to be monitored. And it can also be done continuously, and we know that we do that whenever we are doing conscious sedation or epidural infusion, that type of thing. Some patients need to be continually monitored. So when would we go and do that? When we notice that our patient has an increased work of breathing, they're wheezing, coughing, they're cyanotic. And what's also important to know is your patient's history of their occupation and their hobbies, because that's going to affect their respiratory function as well. So when we go to do that, we want to make sure the patient's on O2 if ordered and it is connected, and make sure everything's all connected up. You get a low reading, and make sure that your oxygen's connected to the wall and that it's running, so that other things that can give you slightly lower values would be patients who have a dark skin coloration. If they're hypothermic, you'll get low reading. They have poor peripheral blood flow. Their hemoglobin level is low. You might get a low reading. If they're moving around, they have any edema, or if they have dark nail polish on, because the beam can't go through their nail. So you can also use an earlobe or a nose or a toe as well. So I'm not going to go through how to do that because you guys all know how to do that. So let's move on to bronchoscopies. And bronchs are done typically at the bedside, or they can be done in a unit, a respiratory therapy unit. They might have a bronch room. Bronchoscopy actually allows the physician to visualize the larynx, the trachea, and the bronchi through either a flexible bronchoscope, which is what you see all the time. There's old ones are rigid, but it's the flexible ones that we see now. And like I said, it can be outpatient in the surgical suite. They can do it in the OR, or they can do it right at the bedside. And it's typically done on patients who are getting, they can also, what I want to say is they can also do it on somebody who's on a ventilator. So if somebody has been intubated and has an endotracheal tube in, they can do the bronch right through that endotracheal tube. So they're looking for abnormalities, tumors, inflammation, strictures. They can also get biopsies. If they suspect lung cancer, they can take a little bit of tissue. Or they can also actually do bronchial washings, where they'll actually put a little bit of saline in, and what it does is it sort of washes off the bronchioles, and then they get some cells that way. Sometimes it's performed for therapeutic reasons, So if there's a foreign body, they might be able to go in and get there. And like I said, the secretions from the tracheobronchial tree, in an attempt, they can do that to treat postoperative atelectasis, and also if they need to excise any lesions or to destroy any lesions, they'll do it that way. So what we do as nurses, we want to make sure our patient doesn't have any allergies, as we always do, and get a consent. It needs to have a consent. Take their dentures out. If they have dentures, get those dentures out. Patient should be NPO 8 to 12 hours prior to the procedure, and we're going to pre-medicate them, typically using viscous lidocaine to numb the throat, or a spray back there, and then typically conscious sedation. Patients can be in a sitting position or in a semi-Fowler's to a high Fowler's, and we would have all our collection and labeling specimens, containers for specimens ready. In the hospital, you're going to see respiratory therapists are assist with this, and the nurse typically is there present to monitor the patient, to provide sedation, and to watch their vital signs. So we're going to be continually monitoring the respirations, blood pressure, pulse oximetry, heart rate, their level of consciousness. And we want to assess their gag reflex after the procedure, after it's all done and gone and all the equipment's out of the room. We want to continue to monitor their vital signs and watch their level of consciousness and their gag reflex and their ability to swallow. It usually takes about 2 hours after the procedure for all that to come back, and they're at high risk for aspiration here. So we want to make sure that we keep them in a high Fowler's position or upright. Do any suctioning that is required, and don't let them eat or drink. So once their cough reflex returns, you can offer them ice chips and then eventually fluids. We're going to watch for the development of any kind of fever or signs and symptoms of infection. We're going to watch their cough. Do they have any hemoptysis that could indicate, maybe any sign of hemorrhage? We're going to watch that because something could have happened when they were in there doing a biopsy, but we'll just keep an eye on it. And we're going to be prepared to intervene for anything unexpected, such as aspiration or laryngospasm. And laryngospasm could happen. That would be a complication. And that's an uncontrolled muscle contraction of the laryngeal cords, which are the vocal cords, and it impedes the patient's ability to inhale. So we're going to watch them for respiratory distress and maintain a patent airway, keep them upright. And if necessary, we would insert an airway. Aspiration, like I said, is another side effect, and that's why we want to make sure that we keep them NPO probably about 2 hours until that gag reflex returns. And then, like I said, suction as needed. For our older patients, we want to encourage coughing and deep breathing every 2 hours because they have an increased risk for any respiratory infections or pneumonias. And that's due to decreased cough effectiveness and decreased ability to clear their secretions. And as we all know, their infections tend to be more severe and last longer. A thoracentesis is a surgical perforation of the chest wall and the pleural space with a large bore needle. It is performed to obtain specimens for diagnosis or to instill a medication into that pleural space or to remove fluid from an effusion, or it could be to remove air from the pleural space just to relieve the pleural pressure. It's performed under a local anesthetic. Typically, it is a pulmonologist that comes in and does it, but it could be a primary care physician as well. Could be a PA. And usually they use ultrasound guidance. Within the hospital, we're seeing more and more that these patients go down to the interventional radiology suites to have this done, but I have assisted at the bedside for a thoracentesis. So usually why they need this is there's transudates, and that could be from failure, heart failure, cirrhosis, nephrotic syndrome. There could be exudates, which are inflammatory, infectious, or neoplastic, which would be cancerous. Empyema, which is pus, could be from pneumonia. There's fluid in there that needs to be relieved. Or if they've had a blunt, crushing, or penetrating chest injury. And also invasive thoracic procedures can cause fluid buildup like cardiac surgery or lung surgery. So typically the patient comes in with large amounts of fluid in the pleural space, and that compresses the lung and it causes pain, shortness of breath. And how do we know that? We'll see it by chest x-ray. There will be decreased breath sounds. When we're percussing the patient, it will be dull. There'll be decreased chest wall expansion on that side. And they will have pain because of the inflammatory process that's going on. So typically when we pull that fluid out, it's analyzed. They do a cell count on it. They look for protein, glucose, So they do a whole workup on the fluid. So pre-procedure, we're going to get a chest film, ultrasound to locate the effusion, percussion and auscultation are our assessment strategies. Pardon me. Sometimes as we age, the changes in fat, where our fat is deposited, in older adults, it can be difficult for the individual to find landmarks to insert that thoracentesis needle. So ultrasound is the best way. We want to make sure the patient has an informed consent, and we want to gather our supplies. Typically, you will find a thoracentesis tray on every cart in every unit. So you want to be familiar where that is. The patient is positioned as in this picture, sitting up with their arms and shoulders raised and supported on pillows on an overbed table, leaning forward. If we're down in the radiology suite, we have them still sitting up, leaning forward. And we want to instruct the patient to be very still, because we don't want them to jerk around, because we could put a lung down with this needle, or the physician could, not we. So we're going to assist the doctor. It's strict sterile or surgical aseptic technique. We're going to tell the patient they'll feel pressure. We'll watch their vital signs, saturations, and then we're going to measure the amount of fluid that comes out. Typically, we're going to use, it's collected. Here it shows you in this little bag, but often you'll have vacuum bottles. They're glass bottles where there's a vacuum is created inside them, so when you insert the needle, it assists with pulling the fluid out. The doc will ask you for a vacuum bottles. I always make a practice of bringing one extra, because it's better to have one ready than to scramble around and try and find another one, especially if you have to call downstairs for it. So often it looks, like we talked earlier, it looks like beer. It is a yellowish color, and it has quite a foam head to it. If it is dense colored, you'll see that with empyema, so it would be like pus colored. Or you'll also see that with, if it has lymphatic fluid in it, it'll be more opaque. After the procedure, we want to put a dressing over the puncture site and have the patient on the unaffected side for about an hour. We're going to watch their vital signs, encourage them to deep breathe and cough, and assist with lung expansion. Typically, they feel so much better because all that pressure is relieved from the lung, where they were having difficulty breathing before, and now all that fluid's out. They feel better. And then we'll get a post-op x-ray to make sure that the effusion has resolved, and we want to make sure we didn't cause a pneumothorax, the lung didn't go down. And that's the biggest complication, is a pneumothorax, which is a collapsed lung. And it can occur because for injury during the procedure itself. So that would be an iatrogenic. That is a word you need to know, iatrogenic, caused by something we did. And so we're going to watch the patient for pneumothorax. We're going to look at their vital signs. Typically, we're going to see tachycardia with that and diminished breath sounds on the affected side. Bleeding can also be a complication. If bleeding occurs, we want to notify the physician, definitely. We're going to look for coughing, hemoptysis, watch for vital signs, check their H&H. That happens usually if the patient moved during the procedure and something got scratched against that needle. And then we're going to watch for infection, and that could be, well, if bacteria was introduced with the needle, if the site wasn't cleansed well enough. So we want to make sure that sterile technique is maintained, and we're going to watch the patient's temperature and signs and symptoms of infection afterwards. Okay, so let's do some ABG's interpretation. You're intelligent students and you want to know more about ABGs, so with that in mind, I'm going to do this interpretation made easy. For simplicity reasons, I'm only going to talk about three basic ABG values. The pH, which is the acid-base balance, the CO2, the carbon dioxide, and the HCO3, which is the bicarbonate. Now we know the normal ABG values are 7.35 to 7.45, that's our pH, our acid-base balance. Our carbon dioxide, which is 35 to 45, and our bicarb, which is 22 to 26. So if our CO2 is greater than 45, it's acidotic. CO2 goes up, it's acidotic. If the bicarb is less than 22, so if it goes down, it's acidotic. If the CO2 which is the carbon dioxide, is less than 35, it's alkalotic. And if the bicarb goes up, it's alkalotic. So those are the things we need to remember. All you have to do is memorize 4 basic questions and then answer them in that order. So is the ABG normal? If all of them are, then you have a normal ABG, and you can stop right there. If any one of the values is out of normal range, then you have to go to the next question. And the next question is the pH acidotic or alkalotic? And to determine this, you look only at the pH. So we're looking at that 7-point-something number. If it's alkalotic, the pH is going to be greater than 7.45, and the patient is alkalotic. If it's acidotic, the pH is going to be below 7.35, and the patient is acidotic. So if we use that number of 7.40 as our middle number, if it goes up, it goes towards alkalotic, and if it goes down, it goes towards acidosis. So anything greater than 7.4 is the alkalotic side, and anything less than 7.4 is the acidotic side, and then it moves out of the normal range of 7.35 to 7.45. So then we want to know, is the cause respiratory or metabolic? So why did it make it abnormal? So to determine that, you're going to look at the pH and compare it to the bicarb or the carbon dioxide. So if the pH is acidotic, you look at whichever value, bicarb or carbon dioxide, so that's CHCO3 or the CO2, and see if that's also acidotic. So if the pH is acidotic, we're going to look at the bicarb and the CO2. Is that acidotic too? Well, then that'll tell us if it's metabolic or respiratory. Metabolic will be the bicarb, CO2 will be the respiratory. If the pH is alkalotic, you're going to look at those 2 values again and see which one is also alkalotic. So you have to match the pH with the bicarb or the carbon dioxide. If the CO2 matches with the pH, you're respiratory. If the pH matches with the bicarb, you're metabolic. And then we want to know if it's compensated or not. Well, what does compensated mean? Compensated means that the pH has moved back into that normal range, and that normal range is 7.35 to 7.45. So it will have moved back into that range, but will still have remained on the either side of the 7.40. So it'll either be on the alkalotic side or on the acidotic side. So if the pH has moved back and it's normal, then we have a compensated blood gas. Okay, let's put that a little bit more simply. Metabolic alkalosis. If the pH is alkalotic and the bicarb is alkalotic, we have metabolic alkalosis. We have respiratory alkalosis if the pH is alkalotic and the CO2 is alkalotic. We have metabolic acidosis if the pH is acidotic and the bicarb is acidotic. And we have respiratory acidosis if the pH is acidotic and the CO2 is acidotic. So then, is the cause compensated or uncompensated? Uncompensated is if the pH is anywhere outside of the normal ranges. So if it's greater than 7.45 or less than 7.35. And it's compensated if the pH is anywhere inside the normal ranges. So that's if it's inside the 7.35 to the 7.45 range, it is compensated. And it will tend to be on either side of the 7.4 if we're using that as our middle point. Okay, so let's try some. So number 1, pH 7.40, CO2 37, and bicarb of 23. I think all those numbers are in the normal range. So we have a normal ABG. That's easy enough. So let's go further on to the next one, because we don't need to analyze anything else, right? We just ask that first question, and that one's normal. So number 2, 7.23, CO2 50, and bicarb of 22. So let's ask our questions. Is the ABG normal? Okay, so we can see right away that the pH and the CO2 are out of normal range. So it's not normal. We have to move on to our next question. Is the pH acidotic or alkalotic? Okay, so the pH is less than 7.35, so therefore it is acidotic, right? Because it's 7.23, that's less. It's acid. Okay, so we know it's acidotic. So we want to know if it's metabolic or respiratory. So the pH is acidotic, and the CO2 is also acidotic. So we have respiratory acidosis there. Now, is it compensated or uncompensated? Well, we know that the pH is outside of the normal range, so it's uncompensated. It's uncompensated respiratory acidosis. That's simple. Let's go on and do some more. Number 3, the pH is 7.36, CO2 50, and bicarb of 29. Our first question, is the ABG normal? Which are the two figures that are out? Both the CO2 and the bicarb are out of normal range. So they're out of range. So we're going to move on. It's not a normal ABG. So, is it acidotic or alkalotic? And if we think about that 7.40 as our middle range and the pH is 7.36, is that right? Yeah, 7.36. So, let's see. It's less than 7.4, so therefore it's on the acidotic side, but it's in the normal range. So is the cause respiratory or metabolic? So the pH is slightly acidotic, and the CO2 is also acidotic. So we have a respiratory acidosis, but it's compensated because that pH is inside the normal limits. So it's inside, the pH is inside the 7.35 to 7.45 range. It's on the acidotic side of 7.4 as we use that as our midline. So it's compensated respiratory acidosis. That's number 3. Okay, number 4. Let's move on to number 4. pH is 7.5, CO2 42, bicarb of 33. So is that ABG normal? No, it's not normal. And we know that some of the values are outside of the normal range, so we'll go on to our second question. Is it acidotic or alkalotic? That pH is higher than our range. It's outside of range. It's 7.5, so it's alkalotic. And is the cause respiratory or metabolic? Well, we know that the pH is alkalotic, so we're going to look for that matching value. And the bicarb is alkalotic, so it matches the pH. So we have a metabolic problem going on here. We have a metabolic alkalosis. Is it compensated? No, because that pH is outside of the normal range. So we have uncompensated metabolic alkalosis. Alright, what's the last one we got here? We have a pH of 7.5 and a CO2 of 18 and a bicarb of 24. Is that ABG normal? No, the pH and the CO2 are both out of normal range. So, is it acidotic or alkalotic? Well, the pH is alkalotic side. 7.5 is on the alkalotic side. It's high. And is the respiratory or metabolic? Well, the pH is alkalotic and the CO2 is alkalotic, so therefore we have respiratory alkalosis. We have a respiratory problem. Compensated or uncompensated? We go back and look at that pH again, and it's 7.5, not in our range, so it is uncompensated respiratory alkalosis. So if you just keep practicing these, and you use it or you lose it. So I have to refresh myself with these all the time, but once I get going on them, it's automatic. You can do it in your head by just looking at the numbers. So if you remember those questions to ask yourself, the 4 basic questions: is it normal? Is it acidotic or alkalotic? What caused it? Respiratory or metabolic? And is it compensated or uncompensated? You can make this really simple, or you can make it very complex. There's many different ways to do it. If you go on Blackboard, there's a couple of tutorials. Some people will learn it different than others. This is the simplest way I've found to do it.